All right, so good afternoon, everyone. Thank you so much for joining our December Behavioral Health Advisory Group meeting. We are really glad you were all able to join us before kicking off your holidays. So continue to introduce yourselves in the chat, and I'm just going to briefly go over our agenda before we jump into our presentations today. So to get us started today, we are very fortunate to be joined by Dr. Shatia Blunt. She will be presenting on the Maryland SB 108 advocacy that has to do with the annual behavioral health visits and advocating for those policies. We'll introduce some open Q&A time for folks to be able to ask any questions to Dr. Blunt while she is with us. And then we will open the floor to Cheryl and Carlos to present on the Fund Maryland 988 presentation. And then we will wrap up with some community announcements and let everyone get on with their Wednesday, if that sounds all right to folks. All right, so to get us started today, I see we have some new faces on, or if you haven't been on in a few months, if you'd like to hop off of mute and maybe introduce yourself with your name, organization, and any holiday activities or traditions that you're looking forward to the most.
Hey, this is Kent. I'll get started. I'm Ken Alford. I'm the former chair or co-chair of Behavioral Health Advisory Group. I left you guys about probably 2 years ago, 3 years ago, become a chief nursing officer. I'm now back in the DMV. I am the director of nursing for the Recovery Centers of America, which is located in Waldorf, Maryland. We provide substance abuse recovery for patients in the 30-day detox and rehab program, very, very high structured, as well as medical management for those in withdrawal independence.
Welcome back. Thank you so much for joining us. And are there any holiday activities or traditions you're looking forward to coming up?
I'm finishing a grueling semester of school, finishing my doctorate in nursing. I just want to rest.
And rest you shall. Excellent. Well, congratulations, and certainly rest up in your break. Right. Anyone else who would like to introduce themselves, or anyone who has been with us and wants to come off of mute and share any holiday activities or traditions that they're looking forward to?
Hi, I'm Tracy Belton. I'm the resource coordinator for the Department of Juvenile Services. Kim Atkinson, who is usually the person that attends these meetings, tomorrow is her last day. She's retiring. So moving forward, either myself or Kathy Halliday Crawford, who works in my office, will be participating in these meetings for the department.
Great. Well, welcome, Tracy. Thank you so much for letting us know that, and congratulations on her retirement. All right.
I'll let her know.
Thank you so much. All right. Anyone else? And feel free just to continue using that chat function if you would like to. I will be taking notes on some holiday activities and hopefully adding them to my my time off. All right. Well, we will go ahead and get started with one of our exciting presentations today. So like I mentioned, we are very fortunate to be joined today by Dr. Shatia Blunt, who will be discussing the Maryland SB 108, which is the annual behavioral health visit policy. So Dr. Shatia Blunt is a licensed clinical social worker and prevention scientist. She brings over a decade of expertise in psychotherapy, leadership, coaching, training, and education. Founder of I and Me LLC, a mental health organization dedicated to nurturing Black mental health, Dr. Blunt's multifaceted career spans public spans public child welfare, juvenile justice, clinical roles, and leadership positions within the Washington, D.C. metro area. Recently earning her Doctor of Social Science degree, she explores the cultural dynamics affecting parent-child relationships, as well as a social determinant of mental health. Passionate about mental health policy, Dr. Blunt is deeply engaged in advocating for Maryland SB 108, a policy requiring private and public insurance providers to cover an annual behavioral health visit. Her diverse skill set and profound understanding of cultural factors shaping mental health experiences within the Black diaspora makes her a sought-after authority in her field. So thank you and welcome, Dr. Blunt. And I will allow you to share your screen whenever you are ready.
Can you hear me?
Yes, we can.
Okay. So let me share now. Nice to see you all. I am going to share this tab. Are you all seeing it? IME making the case for mental health parity and illness prevention. Okay, so thank you. So good afternoon to all, and thank you for your time today. Thank you, Taylor, for a very nice introduction, and thank you all for your openness to learn more about the annual behavioral health visit policy initiative that I am heavily involved in. So as mentioned, my name is Shatia Blunt. I'm the CEO of IME LLC, a mental health organization dedicated to nurturing Black mental health. And this is done by offering direct services such as psychotherapy. I also offer clinical supervision to students, pre-licensed and early career professionals servicing Black populations, and also policy advocacy now, which is why I am here with you today. And so I want to discuss the proposed policies, Senate Bill 108, which covers an annual behavioral health visit from the perspective today of a practitioner and prevention scientists focus on mental illness prevention. So let's go ahead and get started. And so first, the bill sponsors. So on the left, you see Senator Malcolm Augustine. And so I met him maybe a year and a half ago now. I was at a mental health fair at Bladensburg, Maryland. And I was there with my staff at the time, and we were just doing like a community event. And one of my staff brought the senator over to me. I did not know who he was at the time. And he was asking me why I didn't accept insurance, right? And so I'm ranting and I'm raving and I'm talking about how insurance requires me to puts me in ethical dilemmas, right? And so, and he's like, tell me more about that. And I'm like, well, it makes you have to diagnose and it makes you have to, do certain things in order to be paid. And I just don't think that it takes a prevention stance. And I'm like, there's this bill in Colorado where they have allowed an annual behavioral health visit. And, I think, that's very, what's the word I'm looking for? It's like cutting edge in mental health policy. And so he's like, well, let's do something about it. So I'm like, well, who are you? Right? And he's like, well, I'm a state senator, Malcolm Augustine, District 47. So let's meet and let's talk more about it. So he and I had a meeting and I expressed to him from the position of a practitioner, he has done a lot for mental health policy in the state, and he has taken this on as the sponsor in the Senate. And just this year, I learned this on Monday, we're now going to have a cross-reference where this bill will also be presented in the House by Delegate Woods. So, so next is, did you know, right? Because the senator didn't know. Did you know that behavioral health insurers only pay for illness when services are rendered by qualified mental health professionals, meaning that there's no payment for services unless there is a diagnosis listed on the billing sheet? Did everyone know this? I can't see everyone on my screen. So if somebody can come off mute and say, did you know this or did you not know this? You knew this. This is common for you folks.
Yeah, you have to have a working ICD-9 code for billing, and they have to
Yeah.
have and you can't even have, if you go into Access 1, Access 2, can't be like a personality disorder. You don't get billed for borderline personality disorder. You can't bill for narcissistic personality. It has to be an acute mental health illness, mood, or cognitive.
Okay, I did not know that. Also, you could not have what we did access to at the time. Okay, or
As your primary, as your primary.
as your primary. Okay, okay. So yeah, so you all are well versed in this. What do you think about it? What do you think about the policy as it stands, or the practice as it stands?
I think I was just going to say, behavioral health it involves the whole person. And, we get from a medical, physical, we get an annual health checkup. And there's a lot of people who have medical concerns that also have behavioral health issues that complicate their care. So it should be included. And hopefully, not only will they stop siloing these two benefits, but putting them together.
Yes, so integrate their model. Yes,
yeah,
like
I agree. I agree. And you know what else, Margaret? It puts the head back onto the rest of the body.
Right, right. Yeah, we're walking around with no head in the medical side.
Exactly.
I love that. I'm gonna write it down.
That would be, yes.
You
Okay,
can quote me, Dr.
It also.
Someone else?
It also it also is not prevention based. If someone comes to see you before they're critically mentally ill or having a crisis, then it doesn't pay for that. I mean,
absolutely.
You don't always have to have a serious diagnosis to need the help of someone. And you wouldn't, they're trying to get people to do preventive somatic health, but who is preventing a untreated but not diagnosed mental illness, because they start much younger. Than you wouldn't give somebody who initially at 5 years old has this problem. And if you have a child, if you've ever had a child who has ADHD, you can't get any help until somebody slaps that diagnosis on them.
Absolutely.
And then and having worked in the field a long time and always gotten lots of records, I've seen where people come with like 15 different diagnoses, because once you have it, it never is taken off the list.
It follows you. Absolutely.
Wow.
So one more, I see one person have their hand up, or two more people, and then we can move. The question is, what do you think about this practice so far? And Taylor, if you can help me, I don't know how to acknowledge the hand in the chat. So
I just saw the hand go down. Andrea, did you have anything to add?
No, that's it. I just forgot to take my hand down.
That was Andrea. Okay. Anybody else? One more person, or are we okay to move on? Thoughts about this practice?
Larry, you're on mute.
I'm on mute.
No,
I'm so sorry. I'm so sorry. What I was going to say, and thank you for raising this topic. Now that I'm turning 60, I remember the days when this issue didn't take place. It really occurred because of managed care, and they were trying to, limit the number of sessions and, create some definition of why someone was being treated, to contain their costs. And I think you raise a very good point that there should be sessions just for preventative work, and that might ultimately save them money, down the road. So it wasn't always this way, but there were providers who, were psychoanalytic, and they were offering many, many sessions to people, and the insurers wanted some way, to manage what is the right amount of care for people. And I think they've gone to the extreme. And I think what you're suggesting is, really great idea. So I thank you for it.
Of course, yeah, it created this medical necessity criteria, right, in order to access behavioral health services, which is quite opposite of a prevention model. So let me see how to get back here. Okay, so no payment without diagnosis. As you all have indicated, this is not the same for other healthcare practitioners. You go to your primary care annual visits, and you can go to your doctor and they can run all types of tests, and then you leave with a hey, you're doing great, keep it up, come back next year, right? Or hey, this is kind of elevated. I want you to try to, before we think about medication, see if you can handle this with some environmental or some diet changes, and then come back next year or come back in 6 months, right? And there's no requirement for you to be diagnosed with anything at that moment. Also, we see this with woman gynecology visits, right? You hit your annual exam, or if you're a low risk, you have exam every 2 years, but you have this access to your provider without the requirement of cost sharing. Oftentimes, either there's a very low copay. You don't have to pay any co-insurance or any of that, and you're not leaving with a diagnosis at that time. We see this with preventative dentistry. You get your biannual cleanings, right? You don't have to be diagnosed with the cavity to get your teeth cleaned, because the teeth cleaning and the exam and x-ray once a year just make sure that you are on the right track, and you can leave with, hey, floss more, use this anti-cavity type of a toothpaste, build your enamel, and we won't have any problems with cavities, right? We also see this with eye exams. So very interesting, right? The eyes are in the head, the teeth is in the top part of your body, but something about the brain requires us to have a diagnosis if we want to have some preventative work done around that. So no payment without diagnosis also causes ethical dilemmas for practitioners, as we all just spoke to, especially for those, for many of us who are practitioners, and for those who are working with children. So who here works with children? Someone mentioned it before. Raise your hand or speak out. I'm a very didactic presenter. I like to feel the people in the audience, so I don't want to just talk to the screen. So anybody here work with children? Yes? Head nod.
I do.
Okay, sweet. Thank you for responding. So sometimes what we know about children, sometimes children are having a very adaptive response to their environment, right? However, in order to be paid to get services, they have to have a diagnosis when they are not necessarily ill, right? Like if we really want to have a comprehensive view of what's happening with the child and how they are coping with their disempowered position in their homes or families or schools or environments, sometimes the behaviors are modes of communication that are quite aligned with the severity of whatever it is they may be experiencing. But somehow, when we now attach a diagnosis to that response, and as someone mentioned earlier, that it's going to travel with them throughout their lifetime, it can make it very difficult for them in a lot of ways, especially when you have folks who just look at a diagnosis as if it is the problem, as opposed to the symptom of a problem. So for those of us who work from a culturally humble space, right? This may make, to the children issue, I'm sorry, this also may make early intervention difficult because the child may only get referred to behavioral health practitioner once they have moved into a crisis mode or have increased symptoms. So meaning that with this policy that we're suggesting, it will be normalized to go see a mental health care provider. So this also addresses stigma. It will be something that you do every year, as opposed to something that you only do when there is an emergency or something is wrong per se. So this type of policy will represent a cultural shift that is necessary for us to really combat stigma at a policy level, as opposed to having policies that inadvertently support this stigma mentality. But we speak as practitioners that we want to be, anti-stigma, but we don't have the policies to support that. So for those of us who work from a culturally humble space, this requirement may make it difficult, and because it requires you to apply stigmatizing labels when it may not be necessary, right? Sometimes, as a practitioner myself, who didn't accept insurance for a very long time, for this very reason, I found that sometimes you do better work without telling the client or having the client have a diagnosis, right? Because sometimes this diagnostic piece can be a barrier. And I've also experienced it, to be fair, where it is very affirming for a person. And so I think that, practitioners should have that option in terms of how to use it in the actual work, especially when you're in the very beginning, right? Because the pressure to meet with a person for however long, 20 minutes, 30 minutes, and now you have this. A lot of clients that I've experienced become very offended. Like, you don't even know me, you haven't spent any time with me. How is it that you can just tell me I have this? You don't know me, right? So it makes it very difficult for, especially in communities where accessing traditional psychotherapy in this way is not culturally recognized as valid. Oftentimes, it can create additional barriers of folks wanting to access this service. For those of us who work from a social justice stance, it makes it difficult to validate very adaptive responses to a difficult and unjust society. Instead, it labels, sometimes there's this labeling as an internal deficit that one may have. So I remember during the uprisings in the city, I volunteered with some mutual aid programs to provide free support to protesters, right? Protesters, and they were heightened. The amygdalas were very, very much responding. They're on the front lines, and I found it very important for me not to say, well, something is wrong with you, right? There was no requirement for a diagnosis. It was a person showing up in a space to support a person who's advocating for rights in an unjust system. So to that end, sadly, many clinicians provide diagnosis without disclosing to the diagnosis to the client. Sorry, there's a typo there. So this adjustment or disorder, right? If I can't remember the code off the top of my head, but it has become the go-to diagnosis that people just get oftentimes, while clinicians are still trying to make assessments to figure out how to support the client. But because after the first visit, in order to be compensated, you have to have something on the paper. Oftentimes people are diagnosed with adjustment disorders, with mixed anxiety, or with anxiety and depression, and they don't even know it. So we have now begun to engage in an unethical practice of just diagnosing for the sake of it, but not really sitting down and having a talk with the client to say, this session means that you will have a diagnosis when you leave. So what I begin to do in my practice, and luckily I'm in private practice, so I can make many of these decisions, is that once I decided to accept insurance, because the recession was happening and people, many of my clients were feeling like in their discretionary spending, they didn't want to continue to pay out of pocket for therapy. I made a decision, because I want to be accessible, that I will accept private insurance. But at that time, we had conversations around, now this means that you will have a diagnosis on file, right? And some clients didn't care, and some clients were like, well, no, I'm a gun owner, you know what I mean? And I am really serious about my, what amendment is it? Second Amendment? Whatever the bear arms amendment is. I'm very serious about that, and I don't want anything on this record, in this record. And other It's like, oh, I don't want this diagnosis to follow me, so I'll continue to pay out of pocket and still engage very thoroughly with my mental health. So current policies that work. There are some policies that work, right? So we have the Maryland Mental Health Parity and Addiction Equity Act, which mandates coverage for mental health and substance abuse treatment, including outpatient treatment, partial hospitalization, and inpatient treatment. But this policy alone does not focus on prevention, mostly treatment, right? Which is important. Please, I want to impress upon you that I do know that there are different levels of prevention, right? Because the person can be in treatment and you are trying to prevent the issue from getting worse. I understand that, but I am talking about this kind of primary and secondary prevention more specifically. So in an attempt at prevention, the Affordable Care Act combined with the Maryland Mental Health Parity and Addiction Equity Act combined to put in place preventative services like mental health screenings at no cost. So those of us who have private insurance, I know my insurer every year, they send me a PHQ-9 or some kind of a screening. When I go to my primary care, she asks me the depression questions, and then that's about it. Some insurance companies do it and some of them do not. So there's still some gaps in even being able to implement this prevention policy to this day. And so Medicaid also requires screenings for Medicaid eligible children for mental health conditions under the early and periodic screening, diagnosis, and treatment mandate in federal law. So to speak about children, this particular policy is for private insurers on the public insurers and private insurance for adults. On the private side, children will also be covered under this policy. On the public side, SCHIP program, this policy does not necessarily apply to children recipients of Medicaid, but there is another policy that is being drafted by CLASP that addresses the needs of vulnerable children. And so I'll talk a little bit about that at the end, and I know that Taylor will send out some resources about that in the follow-up, okay? So also, with that in mind, did you know that current mental illness prevention efforts emphasize screening in collaborative and integrative care models? I know you all know this because you spoke about it earlier, but most screenings are for anxiety, depression, and substance use. And there are over nearly 300 behavioral health diagnoses, and many of them can only be assessed by completing a comprehensive psychological assessment, as opposed to a short screening during a primary care visit. You're right. So we understand that this legislation was introduced last year, and one of the opposing arguments was from the insurance companies. I guess they were the major opposition at the time, and they were of the belief that screenings are the best option. Let's train doctors to be able to do a screening at the primary care visit, address the issue of somatic care and behavioral health care silos, and have this in this integrative care model. But when you, some of the research that I read, like doctors are feeling ill-equipped, to be able to operate the same way that a behavioral health specialist would operate. A screening is important, but that's very different than a comprehensive assessment that you can get in 45 minutes or an hour with a trained behavioral health provider. So what are we proposing? Maryland Bill SB 108 is requiring certain health insurers, nonprofit health service plans, and health maintenance organizations to provide coverage and certain reimbursement for annual behavioral health visits. The Maryland Senate Bill 108 will create a healthcare infrastructure that supports mental illness and substance use prevention at all levels, strengthen health parity laws, and promote mental wellness, right? And so there can be mental wellness before mental illness. And then even if, depending on how you look at it, there also can be wellness in concert with mental illness, right? So this law is a very beginning piece of legislation, proposed legislation that will begin to talk about prevention in this space in a way that is different from screening. So a behavioral health wellness visit is, these are the definitions, a clinical encounter during which a healthcare practitioner conducts an assessment to identify whether a patient meets the criteria for a psychiatric or substance use disorder. And the healthcare practitioner means an individual who's licensed, certified, or otherwise authorized under the health occupation's article to practice a health occupation and whose scope of practice includes the provision of mental health and substance use disorder care. So also in the behavioral health wellness visit, in the language of the legislation, it speaks to how the person can leave without a diagnosis specifically. It also speaks that the person, the practitioner can give a recommendations for care or referral for care or prevention recommendations and et cetera. So the potential benefits, behavioral health care is normalized from childhood. I spoke a little bit about that earlier. It's just where you go. It's fine. Just like going to the dentist, just like going to the eye doctor, you go to a behavioral health professional. It reduces stigma, especially in minoritized communities where it is not the norm to engage with this traditional type of psychotherapy, whereas other forms of help are more normalized. It's a focus on wellness and early intervention. There's more time for a comprehensive diagnosis if needed. I believe the legislation says up to 60 minutes, so you get the full hour. Oh yeah, it's here. 60-minute assessment allows for more time to build relationship and provide psychoeducation as opposed to what you may get in a brief screening. And it presents less ethical dilemmas around diagnosis for clinicians. And my thought is that, you know, more clinicians may be open to working with insurance providers if there are less barriers in the way as it relates to ethical dilemmas. So there was an analysis done, actuarial analysis done by Axine Health Partners, December 5th, 2023, as a result of some of the advocacy that was done last year on the policy. And this is what we know from the analysis is that this mandate is expected to increase premiums by 0.05% or 37 cents per member per month in 2025. And this is to speak to the opposition of the insurance companies to say, oh, the utilization and the cost will skyrocket, right? So this is the analysis was done to be able to respond to that. So there will be a 2% annual increase in the percentage of patients receiving treatment as a result of the mandate, and there will be a medical savings of 2.5% of total costs or 0.04 per member per month for each new patient. So one of the participants here spoke about that earlier. There may be some cost savings in this, because what we know is that prevention costs less than treatment, right? If this annual behavioral health visit can see the early signs of some sort of disorder, an intervention now is better than a hospital room, emergency room visit. And so I think it's Mental Health America, their campaign is before stage 4, right? So we see this in cancer, right? Where it's like you want to catch it early. So they're utilizing that. Mental Health America is saying the same thing. Let's catch this early. We know that there are social conditions. We know that there are biological conditions, and we know that there are risk factors for certain mental health disorders. We know this, we have this knowledge. So I really believe that this particular policy is the application of this knowledge, which is indicative of wisdom, right? Wisdom is the application of knowledge. So to know it is one thing, but to apply it is something else. So I learned about this last year when Colorado passed this policy in January of 2023. and it was introduced in 2022. And so at that time, I reached out to Representative Michelson Janae and Mo Keller of Mental Health America, who were the pioneers of this particular policy, and spoke to them about it and got some pointers and so that we can introduce it in Maryland last year. And since we introduced it in Maryland last year, it did not pass. It died in the Senate. Delaware, Massachusetts, Illinois, and I learned Monday night that Connecticut now has passed similar legislation. The difference, Connecticut, they allow 2 visits a year. All of these other states, they allow 1 visit per year, but it's the same, generally the same policy of an annual behavioral health visit. So Maryland, hopefully we're next. Where are we now? This was introduced in legislative session 2023 and it was not passed. Most of the opposition came from insurance companies due to cost, and they view practitioners as specialists, which I thought was quite interesting. As a practitioner myself, I understand that many of us can view ourselves as generalists, right? We have almost like a primary care model. So you have some insurance companies that view us in that way, and some that are viewing us as specialists. And so the argument during testimony last year was from one of the representatives from the insurance company was, you know, everybody has a heart, but everybody doesn't see a cardiologist, right? And so just because everybody has a brain doesn't mean everyone needs to see a mental health professional. And so feeling like the behavioral health workforce would be overwhelmed and burdened by the influx of folks seeking care. So that was one of the arguments. And rightfully so, we are in a behavioral health crisis nationally, and we do have some challenges around the amount of practitioners available to meet the demand. But I also think that there's some other creative ways that we can address that and still see this policy in fruition. So it will be reintroduced in 2024. As I mentioned earlier, there's a cross-file with Delegate Wood, so we'll be introduced in the House and the Senate. The bill has been pre-filed. The hearing date is pending. We're not quite sure when we'll have that as yet. I'm hoping I'll get that information soon so I can plan my travel schedule. Because last year I was on the plane when it was watching it on my phone. And we had several supporters last year. So here's a list of organizational supporters that we had. It's not the full list, but it's some of the kind of major supporters of the bill. Many supported with some full support, and some supported with questions that helped us to be able to draft a finer piece of legislation this particular session. And so we hope that you also would join in advocating or providing testimony. So you can provide support as a part of your organization or as a private citizen. So testimony ideas, you can talk about the ethical dilemma of practitioners, the impact on vulnerable populations you belong to or serve. This addresses parity. We can talk about the importance of prevention. This also covers issues around stigma. And then I think what was missing last year is really a pool of consumers or clients that are affected or would be affected or have something to say about this particular policy. I think I'm a social worker at heart. And so I think involving the folks that you work for and with in policy initiatives is very empowering, especially as folks start to understand how our systems play a role in our everyday experiences. And this can be a very empowering activity. And so with that said, thank you. This is my contact information. Please feel free to reach out to me if you have any questions. I'm happy to help you. If you want to write a testimony or testify in person, I'm happy to help you think through what you want to say, craft it, any of those things. So I'll stop sharing now and I'll turn it back over to Taylor. Thank you. Am I still sharing? No.
Thank you so much for that, Dr. Blunt. And we have a hand raise. Winnie, whenever you would like to ask your question.
Hi, I actually put it in the chat. Have you or someone that is supporting this bill presented it to the boards, to the professional counselor board and the social work boards? Because we typically get asked to support legislation and people come to the board and present on what they're asking.
So yes, Ann Seacott of Policy Partners is a lobbyist that's working on this legislation as well, and I believe that she has spoken to the respective boards, and I do believe that the NASW was listed as one of the supporters of the bill.
They may have met with them, but not us. I'm the board chair, and I have not. This is my first hearing of this bill. So
if you'd like, I would love the opportunity to, get in touch with you and talk more about, having a presentation if you'd like.
Okay.
So Winnie, could you mind popping your, oh, I see it.
I'll put in my board. I'll put in my board email.
Okay, thank you.
All right, Margaret, you have your hand up as well. And you're still on mute.
Thank you. I just want to say thank you for sharing this wonderful presentation. And, I think it's perfect timing with the Maryland Consortium really looking on youth and adolescents. So I think, you have a lot of that to also help support you. I know TLC, we work for Totally Linking Care in Maryland and have an HSCRC grant, and we'd be happy to be Carlos, my colleague, is on the line. We do a lot of support around legislation. We've worked with Senator Augustine before, so we'd be happy to help you. And then, I think connecting the dots is really important. And, with the school-based mental health clinics, I think, trying to figure out how do we leverage what we already have to help implement these screenings and strategies. And having worked on a school wellness council, they do the same thing with kids. They take their heads off and they do the eye screening, the hearing, all those screenings, and they don't do the behavioral health screenings. And, I think if we can I always have looked at them as a learning institution. So there's not a better place to start that. I always work for the Healthy Lifestyle Behavior Program and saying you're a learning institution. They should be helping our children learn healthy habits for good physical health, but also for mental health. So I'd like to also maybe encourage, how do we leverage that arena as well, especially in light of the Maryland Consortium that's being out there as well.
Yes, as you speak, I think about the work that's being done at CLASP with Dr. Nia Westbay and her team, and I learned about it when I came to this meeting last time. But what they are looking at is work with transitional age youth, I guess 16 to 25, suspending diagnosis completely if the child meets a what they call it, the criteria, which is like an ACEs. If they meet any of the ACEs criteria, then they will be able to access a range of behavioral health care services without the need for a diagnosis at all. So there is some more work being done in the child space as well. And I agree with you, like leveraging what you already know as well. So if you want to talk more about that, I'll be happy to reach out to you once you send out the email, Taylor. I'll grab your email from there and I can make do an outreach if you don't mind.
Yeah, that would be wonderful.
Okay. Thank you.
And we had a comment from Kent, and he also has his hand up.
Yeah. Yes, it's you in the bill. I noticed it mentioned substance abuse prevention. What does that look like? Because obviously that's my world. Heavily into methadone, Suboxone, Vivitrol, but what does prevention looks like? I really like to hear you frame that so that we can definitely become an advocate for that message.
Okay, so just, I have your information here, I'm gonna copy it, but just in general, you know, understanding what are the risk factors for substance use, right? The risk factors for a substance use disorder, and being able to get in front of that. So as a practitioner, you know, when you're doing a full and kind of comprehensive assessment, you are assessing for all the things, right? And as you move into the person's experience with mood altering substances, you know, you'll know like, okay, this person is they may be at the very experimental stage, or they may be at the pre-contemplation stage, right? And then you can then now start with some interventions, or some preventative interventions to what's the word I'm looking for? Prevent it from advancing to a more intense addiction, because, you know, as practitioners, we think about frequency, duration, and intensity, right? And then there's also some harm reduction models. And so if you can get in, even with us from a psychoeducational standpoint, if you have the visit and know, okay, this person is at risk, then you can provide them psychoeducation, because oftentimes the thing with behavioral health is other people sometimes know that you are at risk of something before you do, right? And so if we normalize this, then that is just off the top of my head how I see prevention working in that space.
Right. So just one last thought, where we struggle here, and I think as clinicians, we're starting to struggle, marijuana has been legalized. It's a nightmare in the substance abuse community on messaging, because it's legal to take marijuana to sleep. It's legal to smoke marijuana down the street. It's legal to have marijuana in your home. As clinicians, nurses, we're trying to figure out how do you figure that, what is the prevention with that, what is the messaging when you are in it, and what is an addiction. So I would love to have this conversation, because we're struggling even with some of the things that we know. Marijuana has really derailed all of us in terms of how we message something that we think might be a harm to a person.
Absolutely. So I've taken down your information, and I'll be reaching out probably at the top of the year, because I'm preparing to take some time off. But I think it's a worthwhile conversation, right? The good news about prevention as a profession, much of it started in the substance abuse space. So there's a lot of resources around substance use and prevention. So I'll be happy to share whatever resources I can with you at that time.
All right. Well, thank you again so much, Dr. Blunt. Thank you so much for giving us your time today. I have put Dr. Blunt's contact information here in the chat. We're going to transition now to our Fund Maryland 988 presentation, just looking at the time so we can wrap up by 4:15. But thank you again, Dr. Blunt. Really appreciate you being here today. Everyone, feel free to continue asking some questions in the chat, and do let Dr. Blunt know if you would like to follow up with her, and follow up with her email there in the chat.
Yes, thank you all for having me. I appreciate your time.
All right. So we will next welcome Cheryl Maxwell from the Black Mental Health Alliance and Carlos Mackel from TLC ND to discuss Fund Maryland 988 campaign.
Thanks, Taylor. And hello, everyone. My name is Carlos Mackel, and I am the project manager for behavioral health and strategy at Totally Lincoln Care, Maryland, better known as TLC Maryland. We work really closely with the health department and the local behavioral health authority in Prince George's County. Very appreciative of the close relationship that we have with them. Also, TLC, Totally Lincoln Care, for those who don't know, is a coalition of 6 hospitals in Maryland, which consists of University of Maryland Capital Region, which has 2 hospitals, MedStar Southern Maryland, and MedStar St. Mary's, Luminous Hospital, and Adventist Hospital. We currently work in Calvert County, Charles County, St. Mary's, and Prince George's County. And a lot of our work is heavy lifting in Prince George's County with helping to support the health department and the local behavioral health authority with creating the crisis continuum, which consists of 911, 988, mobile response team, which is IMINE, Dire Care Center, which is a crisis stabilization center, and then we do outpatient services as well. A big part of that continuum that we advocate for is mining and analyzing data. Where my colleague Margaret was speaking earlier, she also co-chairs this BHAG group. Is really intricate in pulling together this data warehouse, which we are utilizing to mine all of the data, report out on it, look at ways that we can improve systems, whether that's response times, whether that's answer times, or looking at making sure that we are targeting the populations that need services the most. One of the biggest things that we really like to do is improve and support the behavioral health care in all of the state of Maryland, but specifically Prince George's County, improving the care, improving the access, raising awareness, and also advocating for services, residents within the community and the providers, which we see a lot of you on this call today. So that's what brings us to Fund 988 campaign, which I'm a part of, and I really urge and ask many of you on this call if you have the time. I know everyone has a heavy bandwidth right now with all of the stuff you're doing, but if you can carve out some time to support this campaign, I think it will be something that will be really great for Prince George's County. We need all hands on deck. All right, so we can go to the next slide, Taylor. Okay, reimagining our crisis response system. The launch of 988 provides a rare opportunity to improve care. Communities want accessible, reliable place to call that's not just 911 or the emergency departments. Behavioral health crisis should be seen as a key component to our emergency response system. Culture around help seeking can change to promote equity, break down stigma, and reduce criminalization of mental illnesses. Next slide, please. So Maryland 988 helplines. Currently, there's a network of 8 organizations, including Community Crisis Services Incorporated, which is CCSI in Prince George's County, doing a great job here. And within the state of Maryland, we've seen an increase in demand since July 2022, since the launch of 988. Statewide monthly calls has increased by 65% from 3,167 in June of 22 to 5,273 in October of 2023. CCSI calls increased almost 50% from 842 in June of 22 to 1,232 in September 23. Statewide monthly texts increased almost 14-fold from 129 in June 22 to 1785 in October 23. Good performance in 85 to 90% of local answer rate in less than 30 seconds answer time. So the national goal is to reach 95% local answer rate, and Maryland and Prince George's County is well on their way to meeting that goal. We need a further investment, specifically in bilingual counselors, texting capacity, interoperability, and other technological improvements. Next slide, please. Fund 988 campaign. This was founded in 2021 by Behavioral Health Systems in Baltimore, known as BHSB, and hospital partners. And they are committed to 3 principles: establishing 988 telecom fee, expanding the continuum of crisis response services, and integrating crisis services to avoid unnecessary emergency department visits and police interactions. We've also included this website for Fund 98 for you all to go to and look for any information, find out how you can advocate and so on. Next slide, please. Policy success, and I will pass it to Mrs. Cheryl.
Hello, everyone. I want to just give you, I'm Cheryl Maxwell with the Black Mental Health Alliance. I direct a program where we maintain a database that's really international. We have made it our mission to promote a holistic, culturally relevant approaches in developing and maintaining whole health, mental health programs and services for African Americans and vulnerable communities. As you can see from this chart here, funds fluctuate, and we're spending a lot of time attempting to make certain that we have monies that are going to allow us to sustain the 988 fund as it is, and then to also meet the increasing need. Let me ask you to move on to the next slide. Maryland 988 campaign advocacy impact. We've grown to 80+ member organizations across the state, facilitated the submission of supportive written testimony by dozens of organizations, hosted informational briefings with the General Assembly and their constituents, conducted statewide polling showing 79% support for 988 telecom fee, organized a grassroots and public official digital video campaign, pursued a digital ad campaign that resulted in hundreds of clicks, throughs, and also 400,000 impressions, supported an earned campaign that placed 11 stories in national, DC, and Baltimore markets. The next slide, please. Campaign materials. As you can see, we've launched a new website and we have a new brand. Resources have been updated. The new fund, Maryland 988 campaign resolution, the new Maryland 988 helpline fact sheet, the new 988 telecom fee policy brief and fact sheets. All of these materials are available to anyone requesting them. Next slide, please. What's next? Can we move on? Here you can see a map that shows where we have the states that have approved a 988 telecom fee, which is, of course, what our strategy and our goal is for 2024 and beyond. The next slide, please. Why is the 988 telecom fee needed? The Maryland 988 helplines face a fiscal cliff when current appropriations run out. Our state must establish a dedicated revenue stream to address this cliff and prevent future funding cliffs. 988, life-saving, 24/7 mental health support. This is free of charge. The nominal 988 fee is a good idea for Marylanders. 911 has been funded through a $1.50 month telecom fee for many years, and this has allowed 911 to become a dependable public service that we all know. I might stress here that our 988 service will provide to callers consultation, something that is quite different from any other emergency number that we have at the moment, where we're finding when they have the ability, when a caller has the ability to be able to consult with a professional around their issue, oftentimes those issues are able to be resolved just with that call. A 25-cent a month 988 telecom fee would generate $15 to $20 million for 988 and would ensure that 988 continues to grow at a reliable, as a reliable free resource to all Marylanders. 8 other states, including Virginia and Delaware, have created 988 telecom fees. The next slide, please. Annapolis advocacy, the goal to build support for 988 telecom fee, the proposal, and to pass the legislation in 2024. We met with the Moore-Miller administration and legislative leaders. We conducted polling, finding that there is a support, 79%, drafting 988 telecom fee legislation and organizing telephone town halls in December and January. We're planning lobby days, days of action, and digital campaigns during this, the session. The next slide, and I believe I hand this back off to you, don't I, Carlos?
Yes, ma'am. And we can see different ways to join the Fund 988 campaign here, where we can endorse, which you can see the contact information for Dan Rabbit, who's been leading this charge. You know, please, Taylor, do you plan on sharing these slides with the group?
Yes, I will. And I can put this
Okay.
information in the chat as well.
Perfect, perfect. Okay, so that's how you would endorse, participate. You know, like I said, I encourage you all to really consider this, joining the monthly Fund 988 campaign meetings and days of action during session. And last but not least, organize. Partner with campaign to organize grassroots or Annapolis advocacy.
If I might, Carlos, we have our next meeting on January the 5th for 2024, where we will talk about our plans to do literature drops in Annapolis, to collaborate on a lobby day plan. To collaborate on lobby day planning, to discuss calls, action, phone and digital advocacy. That's our call to get the troops to go and get in motion, and then also to plan other grassroots events. Again, and that meeting will take place on January the 5th.
Next slide, please. And last but not least, to contact us, you can see Dan Rabbit as the policy director for BHSB. His information is there, and my information is there as well. And once again, please take some time to go to the fund988.org site, where you can sign up, you can advocate, and you can also get you know, upcoming events and information about Fund 988. We would just like to take this time to open it up now for anyone who may have any questions, comments, or concerns related to the Fund 988 campaign. Okay, Taylor, is there anything in the chat?
I just put in the chat information on that meeting for January 5th, just as a reminder.
Awesome. All right, so we just want to say thank you all for giving us the opportunity to share this information. And I'll pass it back to you, Taylor.
Thank you so much. And Cheryl, could you send that information in the chat one more time? I am not seeing it. I don't know about other folks for that January 5th event.
It should be there now.
Thank you so much. Wonderful.
Okay.
Yes, we will be sure to send that out in the email with these slides as well and the recording of this meeting. Any other questions or reactions to the Fund Maryland 988 campaign? All right. Well, thank you so much, Cheryl and Carlos, for presenting today. Really appreciate you guys. And do let us know if there are any updates along the way. Know that it will be a busy time in January with the legislative sessions. So do continue to let us know and check in with us about anything y'all need or how things are going with that.
Thank you.
Thank you.
Right. Thank you. All right, well, we will open up some time for some community announcements. So first, I don't know if Kim is still on the call, if you're able to discuss the Maryland Department of Health's community survey for their needs assessment?
Absolutely. Thanks, Taylor. So just wanted to share this survey on behalf of the state. The state, like us, is doing their own community health assessment process. And it's important for us to get representation of what we want to see change and the issues that we feel are important for them to consider when they're making their community health improvement plan or their state health improvement plan. So we do encourage everyone to complete the survey so we have representation, and share the survey amongst your partners and your communities. We want to have representation in Prince George's County, because then these data will also be available to us to use for our local community health assessment in the future. So there you'll have, I don't know, Taylor, if you can put the link to this in the chat. The link to complete the survey is here. You just have to be a Maryland resident, at least age 18, and it's very brief. You're really just highlighting the priorities that you think that we need to give more attention to for the health of Marylanders. And just to give a note, I think they were originally planning to close the survey in the beginning of January. Right now, their goal is to get at least 1% of Maryland adults to complete the survey, which would be about 40,000. Right now, I think that they're closer to around 4,000 that have completed. So we need a little bit more work done, and we definitely want that representation so the data are representative of our state and our community. So thanks all for the opportunity to give a plug.
Thanks, Kim. And I put that link in the chat. And also, if folks want to take a quick second, you can also scan this little QR code here as well that will take you directly to that survey. All right, and we will go ahead and open up the floor if there are any other community announcements as we look to finishing out the year or opening up 2024, if anyone has anything to share.
If anyone else wants to jump in, please do. But I wanted to take a minute. For anyone that doesn't know me, my name is Kim Stinchcomb. I'm the manager of the Healthcare Action Coalition. I wanted to take a moment to thank, first of all, we have two new co-chairs this year, Nina and Margaret. Thank you so much for jumping in and taking on that role. We really need the community input and that expertise to help keep these meetings going. And also thanks to Taylor. Taylor's also new with us this year and has done an excellent job of facilitating the meetings, finding us some great speakers, and we appreciate her help as well in keeping this moving. So really thank you all. I feel like we've come a long way in the past year of rebuilding the BHAG after some downtime during COVID. So again, appreciate everything, and we really look forward to a successful 2024.
Thank you so much, Kim. And thank you to all of our speakers today and everyone who has participated this year. We really appreciate it, and we could not spread your knowledge without you. So thank you so much for being here, everyone. So you heard from two great speakers today, a lot of great events coming up to plug into. So definitely add those to your calendar. Other than that, the Prince George's County Healthcare Action Coalition wants to wish you the happiest of holidays and the merriest new year. And we are so looking forward to an amazing 2024 with you all, and hoping that you all stay happy and healthy. And we will see you next year.
Thank you, Taylor. Thank you, Kim. Thank you to our speakers.
All right. And everyone, I can put this link in the chat, but feel free to stay connected with us through our newsletter and share any events going on. And we will see you on January 17th, 2024. And thank you all again for all of your hard work this year, and happiest holidays to everyone.
Thank you.